Good morning. This is Kathi Bush, and welcome to the DandleLION Medical Webinar on Creating a Neuro-NICU, Valuable Insights for All. We're so pleased to have Kathi Randall as our faculty presenter today. Kathi is a neonatal nurse practitioner and clinical nurse specialist with a passion for neonatal neurology. She has been an international speaker on brain development and brain injury for more than 10 years. She is an expert in the use of amplitude-integrated EEG, and has educated clinicians on its application and use throughout the world. Kathi believes that every NICU baby deserves the best outcomes and knows that utilizing the best technologies and tools to care for the entire baby, including the brain, is part of providing comprehensive care. To spread this mission to other NICUs, Kathi has been providing consulting services to assist NICUs in the creation of neuro-NICUs and integration of AEEG into their practice. Currently, she is a program consultant to Lucile Packard Children's Hospital, Stanford, and Loma Linda University Children's Hospital. Today, she'll be sharing her vision of a neuro-NICU, along with practical tips to create a more neuro-conscious practice in every NICU. Welcome, Kathi.
Thank you so much, Kathi Bush, and thank you to all of you for being with us today. It's really always my privilege to be able to talk about one of my favorite subjects, which is newborn neurology. So I guess I'll just get to it because I have a lot of slides and a lot of information. I guess I'll do the disclosures up front. There will be some talk on some of the slides, especially during the neuroprotection section, on investigational and off-label uses of medications and therapies. I do have existing royalty and consulting agreements, but they really have no bearing on the material that I'm presenting today. This is my own, and I'm not being paid to present this. The other disclosure is that on Friday mornings, this is when my gardener comes, so hopefully he and my dog will not be too noisy. I always hate that, so hopefully it'll be okay. The objectives for this morning are basically to list the 4 pillars of a neuro-NICU practice. These are things that will guide us as you're thinking about creating a neuro-NICU or incorporating more neuro-conscious care into your nursery. And then, of course, describing at least 2 neuroprotective interventions that we can really deliver in any nursery on any day. So I thought I would just start with just giving, again, a little bit of kind of my background and what I'm doing these days. So I spend most of my time commuting between Southern California and Northern California, going to Lucile Packard Children's Hospital, which you can see here at the top, as well as spending time at Loma Linda University Medical Center at the Children's Hospital there, and even at the county hospital. So this is my life. I take the Southwest back and forth throughout there to really bring these neuro-NICUs into formation. And it's not just Lucile Packard and Loma Linda that are doing this. This is not something really that's all that new. We have to give credit where credit is due to the vision of University of California, San Francisco, the group at UCSF, which is pictured here, who really were pioneers in this area and in creating this vision of what nurseries could be and should be of the future. If you have not read the article that's listed here at the bottom, which is Neurocritical Care for Neonates by Hannah Glass and the group there at San Francisco, it is an amazing overview and one that's really guided me as I've begun my work in neuro-NICUs over the last several years. But again, UCSF not only the only one. There's also Phoenix Children's, who started their neuro-NICU back in 2009, and then others who have published and who speak a lot on neuro-intensive care and neonatal neuro-intensive care: Johns Hopkins, St. Louis Children's, Vanderbilt, Boston Children's, as well as Children's National in DC. So again, this is not necessarily a one and only practice that I participate in, but obviously dozens of nurseries, not only in the U.S. but around the world, who are there doing this amazing work. So just definitely want to give credit to them, and thank you for their inspiration and their visions as well. So why is this important to us? Why is neuro-NICUs, why are they becoming such a hot topic? Well, really, if we think about it, brain injury is really a reality for any patient who winds up in the ICU. And this is really regardless of age. So neonatal ICU, peds ICU, adult ICU, cardiac, and obviously neuro ICUs. And so it is just with that kind of, mindfulness that brain injury is this reality, that these neuro-NICUs are becoming more and more commonplace. And I think that especially for the neonatal intensive care area, where we are caring for that developing brain, we do want to have a focus on the interventions and the cares that we give that either foster or potentially injure those brains. So when we think about neonatal brain injury, there are obviously numerous causes and diagnoses that go with that, and it's just even too huge of a topic to even begin to really wrap your mind around. But for us, I think when we're thinking about the newborn brain especially, we know that outcomes are very much dependent on location of injury, the timing of injury, super important, the extent of that injury, and then what interventions are we able to provide. So when we're talking about the newborn brain and even the fetal brain, there are these critical periods of brain development that we talk about a lot, and probably all of you have heard of and think about, when you have your basic lectures about neurodevelopment. And so what I just want you to think about is, as you look at this slide, is to just realize that there are certain parts of brain development and these periods of brain development that we call critical, and they're critical because they open and they close. So those are those real critical periods that we make an impact potentially on, that the baby and child never get a chance to go back and redo. So unlike an injury for an adult where all of these periods are complete, a baby, we have the ability to make an impact on these periods that they will never gain access to again. On the flip side of that is the part of it is that, fortunate part really, is that some of these things continue on not only in the nursery, if you're a preterm baby. So if you're a preterm baby, organization is happening not only while they're in the nursery, but beyond, and myelination happening in the nursery as well as beyond. So again, I think it's just important to realize that there are some periods that are opening and closing, but there are other periods that are actually continuing on way beyond that initial period. So the other thing I want to think about is really, where are we now in our practice? So the incidence of neurological disabilities related to these injuries really have not decreased much in decades, and I'll share a few slides on that. And the outcomes of that really are devastating for some babies with cerebral palsy, cognitive impairment, and epilepsy. When we think about leading causes of death and disability still in the United States, again, brain injury is right there at the top. But it's not just these short-term types of injuries and short-term outcomes that we worry about, but the long-term effect of these brain injuries. And we'll go into a little bit more about that as well. For our preterm babies, up to 50% of them can have some sort of neurological injury. Of course, it's dependent mostly on size. Of course, our smallest babies being the most at-risk babies. And of course, they're at risk for the most severe injuries and the most devastating outcomes. If you haven't seen this article that was published back in 2012, this is a great just kind of state of the union of where we are here in the United States. This is Vaughan data published by Hoarbar, but really it's the whole Vaughan collaborative group. And as you look at this graph, you can see that for the babies who are the smallest, so if you look on the left, you'll see the babies from 500 grams to 750 grams. And this is a comparison looking at outcomes and disabilities from 2000 and then comparing the cohort at 2009. So basically a decade apart. So the red line is the line, or part of the graph, is the babies who died. And then you see the blue line are babies who survived, but who had one or more morbidity. And then the space that's left above that, the 100%, is really the babies who survived but had no problems at all, no disabilities. So we can see that about 40-some% and a little bit less in 2009 of babies born between 500 and 750 are going to die. And then the other remaining portion of about another 40-45% are going to survive but have more than one morbidity. And for this Vaughan data, they actually defined morbidity as early and late infection, chronic lung disease, NEC, severe ROP, severe IVH, or PVL. So, of course, this is grouping babies who have, surgical problems, medical problems, as well as brain injury. But again, just giving you that idea that, as that time goes by, and as weight gets bigger, as we look down the graph towards the right to the 1,200 grammars and 1,500 grammars, we see that a smaller percentage die, not even 5%. The blue section being that, up to that, say, 20-ish% are going to survive with a morbidity, and then a greater percentage of those are going to be surviving without. So again, it's hard to know, for their long-term outcomes based on this. We know this is basically survival data, but again, just thinking about that incidence of morbidity and how things really haven't changed much as we look at those kind of paired up bar graphs over the last really decade, and maybe we'll get another look at this data in another few years. I thought it was interesting, if you go back to 1981, that Dr. Levine published this and said, on the basis of our follow-up data, we feel that the size of the hemorrhage on ultrasound is by no means the only guidance to outcome. There may well be other factors influencing the result, or meaning the baby's long-term outcome, which we cannot yet diagnose by ultrasound. And so again, when we look at that data on that previous slide, that was really what we were looking at: severe IVH and PVL, things that can and oftentimes are found on ultrasounds. But what Levine was saying is that there's more to the story than the size of the hemorrhage, and we'll get a little bit more into that. So again, just thinking about these outcomes of our preemies that live in our nursery. Well, I think it's always interesting, and very few of us probably spend time hanging out with 26-year-old preemies, but this is a great graph showing the red babies are the preterm babies, and you can see the blue line are the term baby controls. And don't worry so much about the scoring on the left, but just look at the overall trend. This is looking at IQ scores of premature infants, very, very preterm and very low birth weight infants at 26 years of age. And this was an N of 359 babies. And you see that as we look at the full scale IQ, the verbal IQ, and the performance IQ, we see that preemies perform less successfully, I guess, than their term cohorts. So again, being premature, it's not just that short-term outcome, whether or not they're going to have CP, whether or not they're going to have learning disabilities. This being a preterm infant places you at risk for your whole life. And so when we think about public health things that help us to, prevent prematurity, this is a good thing. I mean, these are amazingly good things because, again, it's important to just realize that being preterm sets you up for just, performance challenges for a lifetime. The other thing, again, thinking about that quote from Levine and about that the ultrasound doesn't tell us everything. And definitely in the 80s, the ultrasounds didn't tell them nearly as much as our ultrasounds of the modern era either. But what I find interesting is some of these other subtle things, things that I really wasn't aware of until just the last few years, about outcomes about our preterm babies. Again, we focus so much like the Vaughan data does, on NEC and infection and ROP, but really there's more to the story. And I think that's really where we're starting to begin to see more of our follow-up data really go to. So on this slide, I wanted to just show you that we have our babies who are preterm on this slide are blue. So sorry, you have to kind of switch your brain. Now, the red are the term babies, and the blue are the preterm babies. And these are psychiatric diagnoses. And so you can see that the blue are the preterm babies. If we look at any psych diagnosis, they have a higher incidence, up to 25% nearly, whereas their term cohorts have closer to, say, 8% incidence of psych disorders. And then when we look at the anxiety disorders, which is the far right one, ASD, anxiety disorders, and we look at the ADHD, we've heard that our preemies oftentimes have these other types of difficulties, conduct issues, not really much difference, but emotional problems, and as well as just this overall increase in psych diagnoses. Again, probably not things that we can see on ultrasound, but these are things as people begin to follow preemies long term, and these are 11 years old, this cohort is 11, we see that there are these differences, these subtle differences, and maybe even not so subtle when it comes to behavior issues in school that our preemies are experiencing. So fast forwarding from Levine in the 80s to Milgram here in 2010, and saying that neither the structural brain alterations nor medical complications common in the NICU can fully explain the variation in long-term outcome. And so again, we're just looking at what is different about the preterm brain and what is different that causes these differences and changes we see between the two groups. So I think, we still don't know many things about the newborn brain, but many people are looking for ways to try to explain and understand and follow these babies. So another just interesting thing I thought I would just bring up is just the frequency of autism spectrum disorders. Again, these subtle changes that are happening in our preterm brains. Basically, you can look here at the yellow line are the term cohorts, the blue line are the preterm babies, and then it was basically looking at autistic-like behaviors, and this is looking at the number of expressions or the types of autistic expressions that these kids had, and you can see that for term and the preterms that we've got, up to, kind of a normal, kind of spectrum there, like one or two behaviors or personality characteristics that we see kind of as, generally through 0 to 5, it's kind of similar numbers. But then as we start to get beyond that, we're 7, 8, 9, 10, 11, 12, we see that the preemies continue to have more of these scores of autistic-like behaviors than the term cohorts. You see a couple pop up for the term at 15 and 16 and 19, but then when we look out at 23, 24, 25, and 35 behaviors that are autistic-like, we see that it's the preemies that persist of having more of these behaviors. So yeah, okay, a term baby or term cohort might have more here of the 2 or 3, but it's the preterm baby who just persists time after time of having these autistic-like behaviors. Again, what's causing this? We can't see it on ultrasound. We can't see it on MRI, but we do see it. Oh, and thank you, Jennifer. Yes, sorry. It was ASD stands for Autistic Spectrum Disorders. So on that previous slide, I apologize. ASD on this slide, you're right. This is not the anxiety disorders. It's more the emotional on this one. It's the autistic. So again, kind of making my point about that previous slide we were just talking about. But yeah, sorry to clarify. Just want to clarify that. Thanks for bringing that up. It's just nervous brain. Okay, so again, just wanted to just point out that there are these behavioral and psychological issues that we're now really recognizing that are definitely different for our preterm babies. And many people are beginning to really talk more and more about this brain injury, especially newborn brain injury. It's not a static lesion. So it's not that you have this grade 3, you have a grade 4, but it's really that it's this dynamic change in the brain, and that some cells, because of this brain injury, whatever it may be, and even stress, some cells are lost, some cells are upregulated, and some cells just are dismature. They just don't mature in the way that we we expect it to. So again, just not thinking so much about the grade of the IVH, but really realizing that this is so much deeper and so much more complex than really we ever realized before. So many people, and this is a great article, this Dagos in anesthesia and analgesia in 2008. This is a great review of just kind of perinatal and neonatal brain injury. And they do a really nice job of describing the multifactorial issues that are going on with brain injury, and especially perinatal brain injury. So even those things that are happening before the babies are even born. And that things are happening at such a micro level that we still just don't understand. And many people are doing basic science research and other types of research that are really looking at the functionality of the brain, the connections in the brain, to really try to understand some of these things. It's not so much just that these babies crump or these babies code or that they have a grade 3 or a grade 4 or that they have hydrocephalus. It's just that those diagnoses are just not adding up everything for us in the way that we used to think. So we've talked a lot about the preterm baby, but there's also the term baby, and many of us work with those term asphyxiated babies, and we know that they're high risk for poor neurological outcome. We know that HIE or encephalopathy is going to, encounter about 1 to 4 in every 1,000 live births. Many of you are either referring babies out for cooling or doing cooling yourself. And we know that this brain injury happens primarily during that interpartum period. But we also know that there is a high percentage of things that happen way before delivery that cause these babies to present so sick at birth. And we know, and this is why cooling has come to be, is that babies who have this event, these sentinel events right at delivery or near delivery, have long-term major problems, mental deficiencies, cerebral palsy, and seizure disorders. And so that's really why we have started cooling in so many units, and really why it's time for that translation to mainstream. This is just, again, a pre-cooling study that was showing that in 2002, really the overall incidence of poor outcome for babies who are born with encephalopathy. And so, again, about 40%, about 10% would have CP. If they had severe neonatal encephalopathy, it's about 62% poor outcomes, and many times they have seizures. And this is why we were so interested in seeing if we could find an intervention that would make a difference for these babies who are born with HIE. And that's really what the evidence has showed is it can help, but it doesn't help everyone. And we'll talk a little bit more about that as well. The other thing I just want to make sure that we all know about is, this is something that I learned in the last, 3, 4, 5 years, is that overall our babies are more at risk for stroke than any other period of life. So kind of like seizures, we always say that, seizing in the newborn period is more prevalent than any other time of life. Same with strokes. And with strokes, we know that they have many causes and they can be of many different etiologies. But just as an overall risk factor, I just wanted you to just see how big that risk is for our babies. And again, something that we can now identify early so that we can actually get these families and these children support. I mentioned a little bit about seizures, again, birth being the most common time of life for seizures, but knowing that seizures are really that sign of something else that's going on, and that we know that when children have seizures and babies have seizures, that these are going to increase their risk for mortality, increasing their risk for morbidities, as well as increasing their overall risk for long-term epilepsy. And of course, when seizures are combined with HIE, we know that that increases their rate of death and disabilities to an even higher percentage. So we'll talk in a little few minutes about better ways of diagnosing seizures to kind of help minimize the impact of these conditions. So now that we've kind of set the stage and probably, reminded you about all of the reasons why babies in the NICU are so at risk, I thought that I'd kind of turn to now the so what and what do we do? And really here are the 4 pillars that I've created of neuro-NICU care. And we'll go through each of them in a little detail just to kind of talk about what are some of the new technologies and things that are happening for each of them. But it really breaks down to neuroassessments, neuroimaging, neuromonitoring, and neuroprotection. And those are really those 4 pillars that we can implement no matter where we work. So we'll first start with neuroassessment. And really, we can never say enough about neuroassessment and our clinical assessments that we give our babies. We really monitor our babies now from every direction, and heart rate, blood pressure, SATs, end-tidal CO2s, and temps, but really the brain. And we'll talk more about that and the types of monitoring that are now available. So how do we then assess the brain? And I mentioned our clinical assessment. Our clinical assessment is just so important and really critical for us to do and to continue to improve our skills at doing really solid neuroevaluations. But unfortunately for us, our babies are oftentimes sedated, they're extremely premature, and we have varying levels of experience in our staff. So it's just August, right? So for many of you who work in academic centers, July brings a whole new time, and so we've got new learners, and we have different varying levels of experience. And so a clinical assessment is great, but at the same time, we have people who have different subjective ideas about what's hypotonia and what's hypertonia and what's normal for this baby and what's not. So how can we do these assessments, and how can we improve them, and what are some of the tools we can use? Well, we can use things like the Sarnat staging score for HIE. We can use the Finnegan score for looking at babies who are withdrawing, which are babies who are withdrawing from narcotics or other addictive substances, and that can give us a really nice objective way of looking at those. And then we can also use other things like pain scores to give us an idea of how well is this baby responding to our care. Other kinds of neuroassessments that we do every day and maybe don't think about as neuroassessments are newborn screens. So we're looking for diseases that could potentially have an impact and present as encephalopathy. We're looking for screening so that we can intervene quickly with the right nutrition, with medications to help prevent brain injury. Of course, CSF and doing LPs, of course, we're looking for infection and inflammation and those things. And of course, those are neuroassessments as well. Other parts of the world do this a lot more than we do, but looking for visual evoked potentials. They actually put little goggles on babies, and they are looking for the visual evoked potentials and the rate of that. And so what they have found in some countries is that as babies who have post-hemorrhagic hydrocephalus, that as that increases, that the number of visual evoked potentials will actually drop as that pressure increases and pressure on the optic nerve is happening. And so just kind of interesting to just see that those things are happening in other parts of the world. Brainstem, auditory evoked potentials, basically hearing screenings. All of us have to do in California hearing screenings before our babies go home. Well, this is a neuro assessment that we do right at the bedside. So neuroassessment is pillar number 1. The second is neuroimaging, which all of us probably are very familiar with, doing head ultrasounds, cranial ultrasounds, and I think the advances are really in the technology, in the image quality, as well as our realization that there are new windows that we should be using for these as well. So not necessarily only just going through that anterior fontanelle, but using some of our other windows behind the mastoid bone and looking at that cerebellum, because now we're realizing that cerebellar hemorrhages have a huge impact on long-term outcome. Doing imaging like MRI, MRS, and using some of the cool new technology like MRI-compatible incubators, so babies don't actually need to be handled once they're in the suite, or also using papooses that will give us the ability to do sedation-free MRIs. So all of this are great advances and have helped us to be able to do more detailed imaging and learn more about babies' brains. The third pillar is neuromonitoring, and this is one of my favorite neuromonitoring to talk about. I love adding this to people's practice. So let's talk a little bit about some of the options. The first is the near-infrared spectroscopy, or NIRS, as many people call it. And this is basically a regional oxygenation monitor. So you're able to apply sensors over end organs of concern, so the brain or the kidneys or the gut, and able to look and see how well those areas are perfused. So as opposed to putting a pulse ox on a hand and kind of getting an overall systemic look, this is really saying what is the perfusion and what is the oxygen saturation levels at these end organs of concern. And of course, today we're talking about the brain, so of course we really care a lot about the cerebral perfusion. Another monitoring that all of us are familiar with is EEG. And I always show this slide because this is actually a baby in Haiti who is being remotely monitored by a team of physicians in Miami. And if many of you are working in nurseries that are trying to add EEG to your practice, one of the biggest frustrations is getting the IT situation sorted out so that your neurologist off-site can see your EEGs and so that you can get those consultations without having to transport babies to other facilities or maybe just not even needing to have your neurologists come in from home in the middle of the night to consult on something. So I show this because I feel like if they can figure this out from Haiti to Miami, certainly we should be able to figure it out across town. So again, just gives us hope, I guess. But EEG, extremely valuable, gold standard for neuromonitoring. And of course, many of us are already using it widely. One of my favorite things to talk about is amplitude integrated EEG, which is a trend of EEG, and I'll show you a few of those pictures of AEEG if you're not familiar with it here in the next couple slides. But with AEEG, basically what we do is we take a trend, a time-compressed trend of the EEG, and that allows us at the bedside to be able to get a better idea of the overall brain activity of babies, to look at sleep-wake patterns, to look at for potential seizure activity or suspicious areas, as well as symmetry between the right and left sides of the brain, which is obviously really important if babies are having strokes and things like that. So what does AEEG look like, and what babies could we monitor with that? This is a very long list of potential babies who you could monitor with AEEG. And I put this up here only just to say that on any given day, there is probably some baby in your nursery who you could monitor with AEEG, whether that's looking for developmental changes like sleep-wake patterns, being able to time your interventions with those sleep-wake cycles, whether it's to just look and see the overall impact of maybe an acute deterioration and to see whether or not the effect that's had on the brain. And then there's all the obvious things like babies who are having seizures, baby with meningitis, babies who are undergoing cooling, babies with heart disease. So, any given day, probably every NICU has at least one or two of these babies hanging around and could benefit from some monitoring. Again, just like I showed you in that earlier slide, we're monitoring babies from every angle, right? Blood pressure, temperature, SATs. But what about the brain? What about that organ that really is so important to our quality of life? So here's a quick screenshot of what does AEEG look like, and this is from a brains device. And this is basically showing you 10 seconds of EEG. So this is the raw, regular EEG that our neurologists and neurophysiologists would read. And at the bottom half is a 3.5-hour trend of that EEG. So it's basically compressing that and then showing us on the scale from 0 to 100, separating the left hemisphere from the right hemisphere, the overall voltage of the baby's brain. So we look at the minimum edge of the blue band, and we look at the maximum edge of the blue band, so the top and the bottom margins, and that gives us a reflection of the overall strength of the baby's brain. What we want for term babies is for their minimums to never go below 5, and we love their maximums to always be above 10. So with this trend, we can see whether or not the baby is meeting the voltage expectations that we would have for them for age. On this slide here, I'm just showing you just what normal looks like compared to what some abnormal tracings look like. And you can see if you just go all the way to the bottom where you see flat or inactive, basically there's no brain activity. This is just showing just flatness. And then in between are some varying degrees of normal and abnormal. And just showing you that these are the 5 basic patterns. There's really not a lot to it. These are the 5 common patterns of neonatal AEEG. So it's not really hard to learn how to read them. Every time you go to the bedside and look at an AEEG, it falls into one of these 5 categories. And so it's just a really cool tool to give you a better look inside. And this is a long-term look, so we can leave these monitors on for days and days to be able to see that trend. In some hospitals who don't have access to full EEG, this is, or around-the-clock EEG, maybe you only have access to your full video EEG for a few hours of a day, and then your techs go home, and only if the baby's actively seizing are you able to get them to come back in. This is a great tool that allows you at the bedside to have a tool. So whether or not you have techs involved, nurses can learn to apply these sensors and to get these tracings going. So I was talking about seizures, and this is what a seizure looks like on AEEG. This is a seizure that's coming from the right side of the brain. You can see here at around 8:20-ish that there's this massive uprising, kind of like a big giant arch of St. Louis right here in the middle of this AEEG band. And when we go in and actually decompress and look at what was causing this change in the AEEG strip, we find this spike wave pattern that is very classic of seizures. So again, at the bedside, we can use this to identify seizures. And remember, about 80% of neonatal seizures are going to be subclinical. They are going to not be able to see these with our eyes. They're only electrographic. They're not visible. And another scary thought is that after we give our first dose of phenobarb, about 50% of the seizures we could see become physically silent, although the brain continues to seize. So it's important for us to use tools like this that are now available widely. These have been available in the U.S. now for more than 10 years, widely used for the last 10 years, have been FDA approved for much longer than that. But these are tools that we can use all the time at the bedside to give us a better look and a better assessment. These are no longer research tools. These are bedside clinical tools that we can all use in our nurseries every day. The final area, and really, although monitoring is one of my favorite things to talk about, I think probably the area that deserves the most attention by all of us every day is neuroprotection. And so we'll spend a few minutes talking about some of the new ways to think about neuroprotection. So in an amazing article by Jackie McGrath in 2011, she really went through and reminded all of us that neuroprotection is really more than just preventing injury. We used to always say that it was just doing things that helped to prevent cell death. And although that is still a huge part of neuroprotection, we are always trying to prevent cell death. It really now we think about it as encompassing all those interventions that not only prevent cell death and prevent disabilities, but promote normal development. And this neuroprotection is being used in a diverse range of populations, from near drownings to the NICU, and adult populations. So we're really seeing neuroprotection as that hot topic right now. So in PEDS and NICU, we're really seeing that neuroprotective strategies and interventions are becoming standard of care. Like earlier, I talked about cooling babies, and I just mentioned near drowning babies. And overall, these interventions are going to fall into one of 5 primary domains. And I did a whole 1-hour lecture on just these 5 domains, so I tried to really quickly summarize these 5 domains for you here today. So again, we're talking about redefining what is neuroprotection. Well, number one, and always number one, is going to be prevention of injury. So doing those things that we already know prevent IVH. So minimizing pain and stress by keeping the head midline, by giving our boluses slowly and gently, minimizing draws, minimizing LPs. So doing those things we know that we can to prevent injury are always going to be number one. Then second are things that are going to contain injury. So this is where hypothermia comes into play for those babies with HIE. So we know that that event has occurred, that brain injury has happened, the baby's presenting encephalopathic, and so we use cooling to help slow that injury, to contain that injury, much like icing your ankle if you sprain your ankle. So containing injury, again, really important. On top of containing that injury, we are looking for many new ways to increase cellular tolerance. So this is really where I was talking about those investigational drugs, things that are coming up and at us now. Things like epogen plus cooling, looking at xenon plus cooling. So looking at ways that on top of cooling babies with HIE, what can we do to help the cells be strong, be able to fight back, to not die after those injuries and all of that cascade of inflammation that happens after these injuries. And this is where we're really going to be seeing the bulk of our research helping to continue to help these babies with HIE, because so many of those babies don't benefit, still babies don't benefit from hypothermia. And so those are the babies we're trying to target, because we don't know which ones are going to do the best after cooling. So we want to make sure that we're figuring out other adjunctive therapies that we can do to help these brains. So one of my favorite cartoon movies is Wreck-It Ralph, and so I like to show this slide because it reminds me that we're also looking for ways to go around and salvage these injured cells. So after the injury occurs, we know that those damaged cells oftentimes cause a massive amount of inflammation and cascade injuries. And so we're looking for that magic bullet that will be able to go in and be selective to those injured cells and being able to go in to help to repair those so that they don't cause those injuries. So much like Fix-It Felix Jr. here with his golden little hammer, we're looking for those medications, those treatments that we can give that will salvage these injured cells. So things like melatonin, again, epogen, these are all things that are under investigation to try to find what is going to be that magic bullet for our NICU babies. The fifth area of neuroprotection is really all about growing and nurturing new cells. So we talked about, yes, we want to prevent, and yes, we want to contain injury, and yes, we want to increase that cellular tolerance. But what about growing new cells and nurturing those cells that we have? Well, just as a little quick overview, again, just looking at those things that are under investigation, epogen, stem cells, IGF, these are all things that are being researched as ways to grow new cells. So that's awesome, that's cool, but what can we do today? Well, I think it's interesting and powerful to know that one of the best ways we can grow new neurons is to provide infant massage and kangaroo care. So kangaroo care grows neurons. I know providing kangaroo care in many nurseries is challenging. Space is a premium. I know in the nurseries where I work, that is really so true. But if you were to think about every time that baby spends time kangaroo care and skin to skin with their parent, that is growing new brain cells, wouldn't it make you all the more motivated to do it every day and to encourage families to find a way to do it every day? This is not any longer fluffy stuff. And if you haven't watched Kara Ann's presentation on massage and touch and Kara Ann's talk on creating a culture of consistent kangaroo care, those are webinars that are so full of the evidence about why these interventions are critical to our everyday practice. It is the little things that we do every day that help grow these neurons, make these neurons strong. So I always think it's important to kind of remind us about the kind of theories that are here for impacting our brain development and this growth of new cells. Well, the first one that I was just talking about is really growing those new cells, wiring and firing neurons together. And this is where that neuroplasticity comes in when we hear people talking about that. But when we think about that, what does that really mean? Well, it means that the brain is moldable and that it is experience dependent and that it's waiting for something to happen. And so we want as much as we can in the nursery, not only to do life-saving interventions, but to do positive things that fire and wire neurons together in a healthy way. The other theory of brain development is the neural pruning. And this is different than the neuroplasticity, where it's experience dependent, meaning it's waiting for something to happen. Neural pruning means that there are all these neurons out there waiting, and that when we use them, those are the ones that wire together and stay strong. So it's a use it or lose it philosophy. So we're waiting, the neurons are there waiting, there's more than we need, and that we need to prune off the ones that we don't need. So what are those things that we can do during these critical periods of development that we talked about to nurture those neurons that we have? So again, thinking about these neurons as being expectant and dependent on activity and experience, and waiting for them to, just explode. So I just want to again remind you that yes, there are periods of critical development, areas that open and close, but that we have the opportunity in the NICU and really beyond to affect that organization of the brain. That experience that we provide really influences the organization and the development of those strong neuron connections. The other thing I want to remind you is the other side of that graph I just showed you, which ends at 9 months, but it's to remind you that myelinization as well as organization continue. And this is a graph just showing over the first 5 years of life, and just wanting to just show you these pathways and how robust they are and how they continue to grow and grow and grow over time. And so when we think about growing neurons, yeah, we're talking about in the NICU, but we're also talking about doing things that promote those neurons for the next many years of life. So what are those things that we can do to nurture the neurons we have? The number one thing we can do is minimize stress and pain. So whether that's providing sucrose, whether that's providing containment, whether that's providing positive touch and positive sensory experiences, what are the things we can do to nurture those neurons? There are so many amazing new elegant studies coming out showing us that babies in the NICU who have had high pain experiences continue to have elevated cortisol levels until their school age, 7 years, 10 years. So this pain and this stress and these early experiences, they change the way that our brain fires for a lifetime. And so that anything we can do to minimize stress and pain will be, reaped benefits for years and years to come. We have had amazing presenters on these webinars, but if you have not heard Dr. Raylene Phillips give her presentation on early parent-child connections, I think it's Early Skin to Skin was the name of that one. Amazing research showing us about the importance of having parent-child interactions, minimizing that separation. Again, I get it. It's difficult. It's hard to do. Parents live far away. Parents have other commitments, have other kids that they can't get to the nursery. But we need to realize that that separation is a stress on our babies, and that that stress causes long-term changes to that baby's brain. Can't say enough about sleep and Mary Coughlin and all the work that she's done around sleep and protection of sleep. And so just directing you to her literature. And I think last but certainly not least is promoting strong bonds with families and really realizing that kangaroo care, having families do massage, those things create bonds with those babies that will last a lifetime. These babies are oftentimes leaving the nursery with many disabilities and many issues, and we need to be sure that those families are committed to those babies. They're going to be taking them to therapy, taking them to classes, taking them to endless appointments. And we just can't underscore that enough. So I've talked a lot about these 4 pillars of neuro-NICU care, and I hope that you're seeing is that, yeah, there are some maybe new things that you're not doing in your practice, but maybe there are a lot of things you're already doing, things that you can continue to do and embrace. And so I think just to wrap up, what I'd like to do is just to kind of run you through a little bit of creating our neuro-NICU. What are some of the things we did? And, of course, give a shout out to my teams who I couldn't do all of this work without. So when you start thinking about neuroconscious care and where your nursery is and whether or not you're doing some of these things or not, I think you can look at making a change, either by creating a true program, a neuro-NICU program. Maybe you just want to try some sort of new unit layout and design. Maybe you just want to change your culture and just, really recognize amongst your colleagues how important all these things are related to the promotion of brain health in your nursery. Regardless if you create a program, create a project, babies every day in your nursery have developing brains. So those brains are going to be affected no matter what. And so I just want to encourage you to just maybe have a new awareness of that and just start thinking about what are ways that we could do a better job than we're already doing. I want to encourage you that Rome wasn't built in a day, and neither will be any change that you create. And in the teams I've worked with, it has been truly a multidisciplinary team. It requires tons of planning and tons of commitment from everyone, and really finding ways to partner with groups of people that we maybe haven't really partnered up with as well as we should have in the past. And I can't say enough about the partnership with neurology and really getting them engaged right from the beginning, and what an amazing opportunity that is. And so, bringing them into our fold and really embracing that discipline in a whole new way has really been eye-opening for me. So when you think about not only the 4 prongs of what a neuro-NICU is, there are really 4 groups of people that need to be involved. It needs to be nursing, needs to be neonatology. We cannot do it without neurology and neurosurgery, neurophysiology. And we can't do it without our family and the families of these babies. And we can't do it without our follow-up people, our rehab departments, our therapists, our follow-up clinic coordinators. We really can't do it without them because these babies are going to need support long-term. And then once you start having this new focus, what should be your focus ongoing? And so these are, again, 4 more pillars to think about: practice, research, new equipment you might need to get, as well as training. So when you think about your practice, the who, the what, the when, who would be these babies? Who would be at risk, and what tools do we need? What equipment do you need to get? What training's required? And then what research to look at outcomes can you envision doing in your nursery? When I started thinking about neuro-NICU, after a while, I started realizing it's almost every baby in the nursery that could be a neuro-NICU baby. So really, it's looking at all babies who are at risk for neurological insults or babies who have evidence of brain injury. But really, in the end, I feel like it's almost every baby who walks through our door could be a neuro-NICU baby. I think the important thing to think about is even in our nursery where we have a neuro-NICU, The babies are only, quote unquote, in our nursery considered neuro-NICU for those first couple critical days of life. But really, it's starting to create this kind of continuum of care, thinking about that discharge and those early referrals and really those follow-up that needs to happen, and especially that relationship that needs to happen with neurology. I thought I would just share a couple of slides about our story from Lucille Packard up till now. So with their love and permission, I will do this. And of course, I want to acknowledge all the hard work and team. And this is a group of us at a meeting just earlier this year. Can't say enough about the leadership and vision of Dr. Krista Van Meers, as well as Dr. Courtney Westhoff, who is our neonatal neurologist. Really amazing group of people to work with. We made a list of our top 10 babies. So remember how I said it could be everybody. What we did was we started by creating our top 10 list of who would be admitted to our neuro-NICU. We opened on April 23rd of 2013, so just about 18 months ago. We trained a multi-specialty team of nurses through a 3-day neuro-focused course. We did hands-on equipment labs. And we continue to do tons of education. We have 5-minute Fridays, we do annual skills days, and then we have an annual course to train new staff. We do multidisciplinary meetings, research, and really continue to strengthen that collaboration across the care continuum, across disciplines, and even with our community, and really with the goal of creating that best brain care that we can. We've admitted a lot of babies, and actually this is an old slide now. We've done up to 300 babies, and we've used a lot of neuromonitoring. 63% of the time using NIRS. We have a lot of cardiac babies. We use NIRS a lot on them, as well as AEEG for our preemies as well. We've presented, a neuro-NICU is a great way to bring focus to a lot of your programs. We sent a group of 12 of us to the International Brain Monitoring and Neuroprotection Conference in Florida. In case you're interested in that kind of thing, it's going to be in Cork, Ireland in 2015. So maybe I'll see some of you there. And I think that there are really lessons through all of what we've done for all of us. I think, number one, it's time to translate research to bedside practice. It's time to expand our care, our NICU care, and our expertise above the clavicles. It takes team, it takes vision, and it takes time. And although, again, prevention is so important, I want you to not neglect the opportunities for promoting brain growth in your nursery every single day. And these are things that we can do, the simple stuff that all of us can do every day. We need to collaborate more with neurology. We need to integrate them into our day-to-day decision-making. We need to make that bridge. We're missing out on a great partnership. And UCSF is a great model. And again, if I just direct you back to that article I mentioned of Hannah Glass's at the beginning, they've done a nice job of outlining, all of what they have done. We need to standardize our approach for these babies. We need to do more monitoring and imaging in a timely way and really systematically. We need to focus on what kind of medications and labs and standardize what we're doing during cooling. We need to get those parents involved at all costs to provide skin-to-skin care and holding. And even with all this extra monitoring, even more, we need to get those families involved. Another important thing that Sue Peliquin and the group at UCSF have talked a lot about is the caregiver fatigue for babies with neuro disease. And so I think it's important that if you start a special team to care for neuro babies, is that you need to have just an awareness that these babies are very high mortality rate, very high disability rates, and despite all of what we do. And so I just want you to care for each other in the unit, especially as you begin to take on a specialized team for neuro. So I hope that I've presented really a why a neuro-NICU and maybe some ways that you can incorporate this into your nurseries. Brain injury is a reality, and we know that the brain is the organ that's going to give us our greatest quality of life. But by having programs, whether it's a neuro-NICU, whether it's a developmental care committee, or whether it's a neuroprotective focus, a program that allows you to identify those babies, use the proper treatments in the timely way, and to really get that relationship going with our neurology colleagues is really the way to ensure better long-term neurodevelopmental outcomes. And that really is what we're all looking for. I just want to take a minute again to just thank all of my mentors, my friends from around the globe who are listed here and who have helped me. So I thank you for this time and your attention. And I guess, Kathi, if there's a couple questions we need to answer, otherwise, thank you everyone for being here today.
Yeah, let's thank you, Kathi, so much. That presentation was fabulous. Let's open up for some questions, so at least people that are listening to the recording, if you have to drop off, we understand. But I'm sure there's questions. The presentation was just chock full of information. One question that came through from Vivian Houghton: does anyone have any literature that makes the link between the use of cuddlers and improved neurologic outcomes?
Not that I've seen. I mean, I think the part about separation, and, you know, we can think about it even in looking at the old orphanage studies of isolation. I think babies are developing beings and we're social beings. And I think that using cuddlers is an amazing idea to give those babies, especially for those families who live far distances or, again, have to go back to work and their babies have chronic issues. No one's looked at it that I know of, but I think it's an amazing idea. I don't know how we would study it, but maybe just by incidence of use or something. But yeah, babies need interaction to develop, and we should use whatever volunteers we have access to.
Kind of in the same vein, Erin Barnett asked, with kangaroo care, do you know if the benefits are the same with non-parents, specifically targeting CPS, no outside contact babies?
Yeah, well, I mean, in other cultures and in other countries, certainly kangaroo care is provided by other people from the community, other mothers. So non-parents, I mean, so you're meaning absolutely no biological tie? I mean, again, I guess I would refer to other cultures. I mean, I think, whether or not we need to just make sure we're giving those babies good, other positive sensory experiences, if one person being consistent, I don't think there's really yet any evidence. I'd probably defer to Sue Ludington Ho on what she would know about that, but not that I really have heard of.
Great. Anyone have any other questions? You should type them in the chat area on the left-hand side of your screen.
So Deb is asking, what do you do to help a NICU create a neuro-NICU? Well, I mean, I think there are lots of reasons why people create a neuro-NICU per se. Some of them is just like they have a very high incidence or a very high rate of taking care of babies with these disabilities. And so things that you can do are just, basically looking at the four things I talked about today. You look at those four things, and whether you create a true neuro-NICU or not, it's what are you doing using the current technology, translating research to clinical practice. I mean, it is beyond time to do it for many of these things. And so I think it's just a matter of whether you call it a true neuro-NICU or not, is just saying, where are we with our practice? And can we do better for all babies that are at risk? And doing the little things, no matter what.
Is there certification for a neuro-NICU training?
So in our own unit, we have created, our own certification, I guess, per se. We have certain requirements for those nurses, and so there is no specialty as of yet, a subspecialty that you get certified externally by. We do some AEG teaching and some certification around that, kind of again internal, but not a per se. Joanne is asking if the neuro-NICU is actually a separate section or part of the unit. This is a great question and a complicated one. So at Lucille Packard, it is a virtual unit. It is similar to providing ECMO or cooling. The babies they're admitted where they're admitted, and the nurses go to them for staffing reasons as well as for space reasons. At UCSF, they actually have a separate section of the unit. And at Loma Linda, it's a virtual unit as well, kind of a unit within the unit. So the babies are admitted to where it's appropriate for staffing and space, and then the nurses follow them. So, other places I know are beginning to create more specialty units. So like Children's in Orange County has a small baby unit, which definitely those babies are Neuro-NICU candidates. So I think there's lots of different models. I think for me, it's the most important thing is the overarching philosophy of, providing good brain care, neuroconscious care. Someone's asking about using AEEG in preterm babies, and are you using this information to talk to parents about withdrawing care? So AEEG is a screening tool. So AEEG in and of itself is not enough to really direct those kind of conversations, but AEEG is enough to get you enough ammunition to pull in your full EEG. And so you want your neurologist to still consult, and you would want a full video gold standard EEG if you're going to talk about redirection. But AEEG can be a great tool to guide you in screening for those things.
Marianne Sawyer asked, do you kangaroo hold babies who are in humidity? Do you have guidelines? Is AEEG certification available?
So that's kind of two questions in one.
Yes.
So for kangaroo, so both the units I work in, we do kangaroo small babies. And depending on, usually it's not during the first couple days of life, but, you give them, a little time to stabilize. And it really always depends on how stable they are. But yeah, we would do it even if they're doing kangaroo. We don't pump in humidity from the outside. We do try to cover them and try to minimize any evaporative losses. I know some places do use like a saran and blanket for that. But I think, what we know about kangaroo care is that the mom will upregulate her temp to keep that baby warm. So I've not seen anybody do anything extra. Certification for AEEG, great question. There isn't really, not to give a plug to myself, but I guess I will. I do have an online course that I offer, and I do lots of trainings on sites and things. But there isn't really a standard AEEG certification. There has been discussions about creating one by many different bodies, but no one has created one yet.
One from Kathi Bailey. You referred to AEEG use in premature infants. Are you using this information when you talk to parents about withdrawal of care?
Yeah, I got that one. We talked about that. There's someone asking about an order for kangaroo care. It's part of our order set, and then if there's resistance and part of our protocol, who we do kangaroo care and who we don't. And if there's an exception that needs to be made, we get an order to override an exception. So that's the only time we get an order.
Okay, I think we've got them all. Kathi, thank you again so much. And this webinar was brought to you by DandleLION Medical, and we are so pleased to have experts like Kathi as part of our webinar series. DandleLION products are based on the principles and practices of neurodevelopmental care. The Neuro-NICU offers very small babies more protection for their developing brains. And our clinical consulting team reviewed the research on neurodevelopmental care before they helped us develop our DandleLION and WRAP. And a few of the features that help with babies' brain development: the brim on the roux protects the baby's eyes from direct light. The stretchy cotton allows freedom of movement that in turn makes neuronal connections. And the multi-purpose roll helps to keep babies well positioned in a posterior pelvic tilt so long-term development is on track. The products strive to provide 360-degree support in order to mimic the womb as best as we can in the extrauterine environment. If you'd like to receive more information on our products, please feel free to indicate your interest on the evaluation form. So speaking of the evaluation, in order to receive your free CE, you'll need to fill out the webinar evaluation. In the chat area, you can click on the evaluation link, or once we're finished, I think Kathi is going to be putting up the evaluation form. You'll be redirected to the link if your firewall allows. At the end of the evaluation form, you will receive a link to the CE certificate, If you don't have time to fill out the evaluation right now, or your hospital has blocked access, you will receive an email within the next few hours with a link to the evaluation, as well as a link to the recording and a PDF of the slides. If you're viewing as a group, you must each log into the evaluation form to get the CE. I hope you'll all visit Dandelion Medical's website for future webinars. We have another one scheduled for October. And also we have links to all the recordings. We have 20 previous webinars recorded now, several of which Kathi referred to. If you go to www.dandelion-webinars.com, you'll find links to all the recordings. They're all still active and available for continuing education credits. So have a great weekend, everyone. Thank you all for your participation. And many thanks to Kathi Randall for another fabulous Dandelion webinar.
Thank you, Kathi.